Alright, here's our case 7, presented by Hao, Ziki, Tom, and Ankit.
Hello, welcome to case 7. In this case, we will be focusing on a suspected hospital-acquired infection where a patient is admitted to the intensive care unit ICU after an episode of motor vehicle accident, who suffered leg and arm injuries. 3 weeks later, he developed a fever. To investigate what caused the fever, swabs from the leg and the arm were taken and they were inoculated on host blood agar HbA, McConkey agar MAC, and anaerobic host blood agar. Gram stain and several of paramedical tests were then conducted.
Alright, for the leg wound swab for Acinetobacter baumannii, we had a plate reading. We did the reading on HbA, McConkey, and HbA anaerobic. HbA, there was growth, white gray colonies, and it was gamma hemolysis. It grew on McConkey, but it didn't grow as much as HbA. The growth was slightly yellow with purple in the center. It was non-lactose fermenting, but lactose is oxidized to weak acid by Acinetobacter baumannii, leading to purple colonies due to presence of indicator neutral red in the McConkey. There was no growth anaerobic, so it was strict aerobe. The gram stain was gram-negative rod. Encapsulated, it was Coccobacillus. We did other biochemical tests like catalase positive, oxidase negative. So we went with API 20 Ne at 42 degrees. The indole result was.
The agar readings from the arm swab were the following. Strong growth in HbA, beta hemolysis was observed, and the colonies were grayish-green, large and round-shaped. For MAC, there were also growth, and the agar turned yellow, indicating non-lactose fermentation. As for anaerobic HbA plate, there was no growth, which indicates this organism is strictly aerobic. The results from gram stain were negative, plump rod, and encapsulated. Now, for biochemical tests, we recorded catalase positive and oxidase positive. Additionally, API 2080 was performed and incubated at 37 degrees Celsius, which identified the organism at this stage, Pseudomonas aeruginosa. Moreover, we also did see 390 antibiotic sensitivity test, and the result was C390 resistant, which further support the API 2080 result.
So here's the leg and arm wound swab of the organism. It had minor growth on all the plates. It grew well in all the plates, HbA, McConkey, HbA anaerobic. In the HbA, it grew with white, gray, and gamma hemolytic. In the McConkey, it grew pink. In the anaerobic plate, it grew white, gray, with gamma hemolysis as well. We did further tests for the gram stain. The gram stain was gram-positive cocci, of course, perfect spheres in clusters. We did further chemical tests, catalase positive, latex coagulase negative, DNA negative, and to further identify the organism, we did antibiotic tests. The organism was sensitive to novaviricin. Now, from here we know the Staphylococcus epidermis is the normal flora of the skin, so further test was required to identify the organism properly.
Antibiotic sensitivity testing was completed using Mueller-Hinton agar plates and antibiotic stamper discs due to the breakdown of the Vitek 2 recently. Both the significant organisms isolated from the wounds are part of the escape list. That is, they are clinically dangerous pathogens with the potential to accumulate or have intrinsically high resistance to antibiotic treatment. While these organisms are not particularly virulent, they are both good at acquiring resistances, which makes them a formidable threat in a hospital setting. They are unpredictably dangerous because they may harbor all forms of antibiotic resistance that have been currently identified in pathogens. Acinetobacter baumannii is an intrinsically resistant organism. Its surface proteins play a structural role in its outer membrane and contribute to the resistance of chloramphenicol, monobactam such as aztreonam, and quinolones such as nalidixic acid. It has been known to harbor metallo-beta-lactamases, ESBLs, and has an intrinsic chromosomal AMP-C which can be upregulated, resulting in a high beta-lactam resistance including carbapenems in some isolates. Furthermore, its chromosomally encoded efflux pumps can be upregulated in response to antibiotic treatment. As such, resistances to tigecyclines, carbapenems, aminoglycosides, and many other antibiotics have been observed. Furthermore, some strains can alter their topoisomerase active sites to become resistant to fluoroquinolones such as ciprofloxacin. Pseudomonas aeruginosa has also been known to harbor metallo-beta-lactamases, upregulated efflux pumps, upregulated chromosomal AMP-Cs, ESBLs, and poorly permeable outer membrane, which results in high intrinsic resistance to beta-lactams, including carbapenems, as well as aminoglycosides, macrolides, and chloramphenicol. P. aeruginosa also has an intrinsic resistance to sulfonamides and trimethoprim due to reduced uptake. Much of its resistance may be attributed to these upregulated efflux pumps. To test for the presence of a metallo-beta-lactamase, A metal complexing agent called termocaptopropionic acid was used in a disc to deactivate the carbapenem and cephalosporin hydrolyzing metallobetalactamase by complexing the zinc ion used in its protein structure. As such, if the organism was positive for the presence of this gene and protein, there would be a keyholing effect observed between the ceftazidime imipenem discs and the 2-MPA. To test for the presence of an extended spectrum beta-lactamase and or an AMP-C, ceftazidime was set up in the middle of an augmentin and an imipenem disc to observe for a keyhole or flattening effect for the ESBL and AMP-C genes respectively. For treatment of the two infections, most beta-lactams should be avoided due to the intrinsic AMP-C in both organisms. If sensitivity is observed for imipenem and there is no presence of beta-lactamase, recommended treatment is with imipenem due to its good gram-negative rod spectrum. If metallobetalactamases are present in either of the organisms, carbapenems cannot be used. We will liaise with the doctors as soon as the sensitivity results have returned. If the organisms are extensively drug-resistant, a colistin/imipenem combination may be required to prevent bacteremia and or sepsis.
Acylactobacter baumannii was isolated from the patient's leg wound in this case. This organism is becoming increasingly notifiable as nosocomial infection or hospital-acquired infection. It is almost exclusively isolated from the hospital environment, especially at ICU, where the IV knives, catheters, and any medical devices that are contaminated with A. baumannii. In a study of European ICU in 2009, A. baumannii was found responsible for almost 1/5 of ventilator-associated pneumonia cases. Patients in hospital can readily get A. baumannii by contacting infected persons and contaminated object surface. Although this organism inhabits in the environment, it is not part of the normal flora of humans. A. baumannii has various virulence factors that contribute to infection. We have listed a few among them. Polysaccharide capsule, which is to prevent complement activation and delay phagocytosis. Fimbrine is for adhering to the bronchial epithelium. Pili facilitates biofilm formation. Since A. baumannii is one of the escape pathogen group which has a high antibiotic resistance, it is now reported resistant to many commonly used antibiotics due to variant resistance mechanisms, such as aminoglycoside modifying enzyme, altered penicillin-binding protein, carbapenemase, and metallobactalactamase. Despite its high resistance to common antibiotics, trimethoprim sulfamethoxazole or Bactrim, doxycycline or Dorix, polymyxin B, colistin, carbapenem such as imipenem and meropenem. Interestingly, although carbapenem is a big flag of resistance, generally speaking, carbapenem is still the mainstay of treatment for A. baumannii infection. However, when the symptoms are worsened, the last resort antibiotic, colistin, is prescribed. To prevent this infection, the healthcare providers need to maintain or improve the standard of high hygiene and sterilization of medical devices. We have also taken wound swab from the patient's arm wound, where Pseudomonas aeruginosa was tested positive. Similar to A. baumannii isolated from leg wound, Pseudomonas is also responsible for hospital-acquired infection, entering through airway, urinary tract, and open wound. This organism is not part of the normal flora of humans. Pseudomonas can be spread by touching contaminated surfaces, such as poorly cleaned hands of healthcare workers or other medical equipment. There are a few virulence factors that facilitate the infection of Pseudomonas aeruginosa. Pili attaches to the cell surface, lipopolysaccharide, which acts as an endotoxin. Exotoxin A is to inhibit protein synthesis. Alginate, which is a capsular polysaccharide that forms biofilm and also inhibits phagocytosis. Similar to A. baumannii, Pseudomonas aeruginosa is also one of escape pathogen group, so it is highly resistant to commonly used antibiotics, such as penicillin, ampicillin, the first and second generations of cephalosporin. Despite the strong resistance, Pseudomonas aeruginosa is sensitive to aminoglycoside, quinolone, third-generation cephalosporin, anti-pseudomonopenicillin such as piperacillin and picatinnin, carbapenem such as imipenem and meropenem. Ciprofloxacin occupies an important role in treatment for gram-negative bacterial infection, especially for Pseudomonas aeruginosa. Also, for the wound infection, acetic acid, which acts as a bacteriostatic agent against Pseudomonas aeruginosa. In other words, it inhibits the growth of Pseudomonas. Fortunately, the infection of Pseudomonas aeruginosa is usually eliminated after 10 to 14 days of treatment. To prevent the spread of Pseudomonas, probiotic prophylaxis is often used in an ICU setting. Also, it is reasonable to avoid water usage, such as pools, hot tubs, and other bodies of standing water. To be thorough, it is important to also take care of the equipment that regularly encounters water, such as contact lens equipment and solution. Even though it is always necessary to have a proper hand hygiene in a hospital, the best hand hygiene practice can't totally prevent the transmission of Pseudomonas aeruginosa, given how common this bacteria is in the environment. To explain the cause of fever of the patient, we also collected 6 blood bottles in order to determine the presence of bacteremia. Staphylococcus epidermidis was isolated from only one of the bottles that we have collected. Since it is only a mild growth of Staph epidermidis, plus this bacteria is actually the normal flora of skin, it is considered a contamination during sampling or handling of the bottles, or an insignificant bacteremia. Therefore, we thought the fever is caused by the protective response of immune system against the wound infections. It is unlikely to be a blood infection of that patient.
The patient's fever is likely to be attributed to the infection of Pseudomonas aeruginosa, P. aeruginosa, and Acinetobacter baumannii, A. baumannii. These organisms have a handful of similarities. They are opportunistic organisms despite having their own colonization in the human body. For instance, A. baumannii colonized the respiratory organs while P. aeruginosa colonized the gastrointestinal tract. Furthermore, they are also non-lactose fermenters which have the ability to quickly develop resistance to antibiotics. This explains why they are listed as one of the ESKAP escape group of pathogens which known to have a high antibiotics resistance that subject to hospital-acquired infection. Additionally, Staphylococcus epidermidis was recorded in all samples collected from the patient, which is believed to be a normal flora from the skin. Furthermore, further direction for this case will involve standardized sterilization method around the hospitals, such as setting up a quarantine room for patients and implement hand hygiene regulation. Wound swabs collected in this case was not done perfectly due to the collection site. Anaerobic organisms should also be taken into consideration should they be the causative organism for the patient's fever. Aspirator in syringe would be an ideal method to collect such sample. To culture the sample, cooked meat medium would be used, and its readings could be included as part of the investigation. Furthermore, autoclaving equipment should be implemented as an additional method to disinfect contaminated equipment to achieve the highest level of hygiene. Additionally, frequent inspection on the Phytech machine is also essential to minimize any contamination from further hospitalization.
Thank you guys. Hope we saved the patient.